Thank you, everyone, for remaining here. I have the honor of being the last speaker before lunchtime. I'll make this real quick. Isthmic spondylolisthesis is often discovered at a younger age, and unlike degenerative spondylolisthesis, it typically associated with back pain, leg pain, plus minus neurological deficit. And neglected or undercorrected spondylolisthesis often leads to imbalance in the sagittal plane and a foraminal stenosis, radiculopathy, and a compromised health-related quality of living. Schaub et al. In their 2010 paper, they described how age-related lumbar lordosis decrease leads to compensatory pelvic tilt increase and decrease the sacral slope, so one can maintain level gauge. And this decrease of lumbar lordosis to pelvic incidence is very closely related to a health-related quality of living. In isthmic spondylolisthesis, as the lumbar spine subluxes in relation to the pelvis, and this decrease of lumbar lordosis is not compensated with increase of the pelvic tilt. In fact, actually, lumbar spine kicks the pelvis posteriorly and increases the sacral slope, and a pelvic tilt decreases. However, that the pelvic incidence remains the same. This decrease the lumbar lordosis to pelvic incidence ratio is closely related to health-related quality of living. In the past, and even nowadays, some of our colleagues advocate stabilizing this isthmic spondylolisthesis with in situ posterior spinal fusion without reducing it. And this is typically the common outcome. As you can see, this patient has developed a chronic non-union with a fractured pedicle screws. And it just makes the job of the guy who's going to have to fix this problem later on more difficult. Surgical approach, there's a traditional postural stabilization, which includes a gill decompression and fusion, and it is associated with extensive muscle disruption and increased blood loss. Of course, there's the option of a minimally invasive TLIP, but my experience tells me that the reduction is not very satisfactory. Anterior stabilization, and when you do anterior fusion for this kind of problem, you are going to need an approach surgeon, and rotational stability is typically compromised. You can do a circumferential fusion, and again, there's going to be extensive muscle disruption and increased blood loss, and it's quite inefficient. In the middle of the surgery, you have to change position and increases OR time. Again, you need an approach surgeon. In my practice, I perform ORLI procedure, which is supplementing the pelvic percutaneous pedicle screw fixation for instability such as isthmic spondylolisthesis and significant deformity, multi-level problem if there's a presence of osteoporosis. And if the pathology involves less than 2 levels, 1 or 2 levels, I perform ORLI anteriorly with instrumentation without using approach surgeon, using a freehand technique. I do not need an IOM because I'm performing ORLI procedures. And I supplement it with a percutaneous pedicle screw unilaterally. And it achieves pretty good stability because I already performed ORLI procedures, and up to 2 levels, it remained pretty stable. And there's a very minimum muscle dissection with a very small amount of blood loss. And it is done also freehand technique. And I do these procedures the whole time keeping the patient in a right lateral decubitus position. It increases efficiency, and it's very easy for the anesthesiologist to manage the airway. And by keeping the patient in the right lateral decubitus positions, your abdominal decompression is much better, and it's more opportunity to decrease blood loss. It is truly hassle-free correction of the grade 2 isthmic spondylolisthesis correction. This is how I position my patient. And my incision is going to be approximately 4 centimeters anterior from the iliac crest, approximately 5 centimeters long, and in line with the L5-S1 disc space. And this is a retractor that I use, a little bulky, but it works very well. And I make a skin incision, and I go through in layers. After I dissect external oblique aponeurosis, I dissect internal oblique aponeurosis until I reach retroperitoneal fat pad. This is followed to inner table of the ilium, and the psoas muscle is palpated, and a common iliac artery on the left side is identified, and the peritoneum is mobilized and retracted medially anteriorly. Retractor is placed. Annulotomy of the L5-S1 is performed. With a Cobb elevator, I try to separate L5 and S1 vertebral bodies apart from each other. If that doesn't work, I use wedge and do the sequential dilation and do the instrumentation. And after that, I supplement that with anterior plating and screws. If there is any significant structural instability, I perform percutaneous pedicle screws in the same sitting, and I use a Jamshidi and K-wires, and with the cannulated pedicle screws. As you can see, that disc space has been elevated, spondylolisthesis has been reduced. I could do all this, very minimum blood loss with a great efficiency. This is a 34-year-old lady and who used to be very active, but she's been not doing anything because of chronic back pain after she got into the motor vehicle accident, and she has a motor deficit as well. And she tried and failed conservative measures. And this is x-rays. As you can see, there's really no disc space between L5-S1, and there's 11 millimeter subluxation with a flexion, and 9 millimeter subluxation with extension, and there's obvious defect in a pars intra-articularis. And this is MRI, no disc at all, and modic change involving most part of the L5-S1 vertebral body and a sacrum, and a severe neuroforaminal stenosis. This was treated only with the L5-S1, the percutaneous pedicle screw fixation, with EBL less than 30 cc, surgical time less than 2 hours. And she went home the next day. And when I saw her in 9 months post-op, she was still doing very well. 28-year-old young lady who has chronic back pain since she was very young, and she has a parallel ankle dorsiflexion EHL weakness, and she also failed all conservative measures. And this is actually performed 14 months apart. Look at the progression of the spondylolisthesis and the disc degeneration. It's quite significant. This is MRI, again, demonstrating severe neuroforaminal stenosis. Again, this lady was treated with L5-S1 only with a percutaneous pedicle screw fixation with EBL less than 30 cc's, surgical time less than 90 minutes. She stayed in the hospital less than 23 hours and went home the next day. So only when a percutaneous pedicle fixation performed in the same position spine surgery, safe, efficient, effective surgical treatment of the grade 2 isthmic spondylolisthesis. I think a further study is warranted to compare with other surgical treatment of the grade 2 isthmic spondylolisthesis and patient outcome, and also biomechanical comparison analysis of the OLIP and the unilateral percutaneous pedicle screws. Thank you.